Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Axome. Are hypnotics safe to use in those with untreated obstructive sleep apnea? This has been an ongoing conversation in sleep clinics that continues to evolve as we have more medications to choose from. Are there some hypnotics that should be avoided in those with untreated obstructive sleep apnea? Which ones are safe to use? Is it reasonable to try to treat the comorbid insomnia before treating the sleep apnea? Should this treatment only be CBT I, or are there some hypnotics that can also aid in COMISA? There was a paper a few years ago that demonstrated that CBT I actually improved AHI. Does this also happen with hypnotics? Joining us today are Dr. Mark Boulos, Medical Director of Sunnybrook Sleep Lab in Toronto and Associate Professor at the University of Toronto. Dr. Atul Khullar is Medical Director of the Northern Alberta Sleep Clinic and Associate Professor at the University of Alberta. And Dr. Michael Mack, Clinical Vice President of the Canadian Sleep Society and Assistant Professor at the University of Toronto. Welcome. I'm glad you could all join us today.
Thank you.
Thank you. Pleasure to be here.
Thanks, Seema.
So, Mark, can we start with you?
Sure.
So we know that there are lots of classes of medications that kind of fall under this umbrella of hypnotics. So which ones are okay and safe to use in people with untreated sleep apnea?
Yeah, so I guess one way of looking at it is which ones are not safe to use in patients with untreated sleep apnea.
Yeah.
The traditional answer would be, are you going to use a high dose of a benzo in someone with untreated sleep apnea? A lot of people would take issue with that. That would be relaxing the airway potentially creating or eliciting more obstructive, potentially even central respiratory events. So there's been a lot of concern and talk around, the benzos, and this has been, traditionally across the years that they could worsen potentially sleep apnea. And same thing even similarly with the Z drugs as well, though to a lesser degree, there is some thought as well in the community out there that you can worsen untreated sleep apnea with the Z drugs, though to a much, much, much less degree compared to a benzodiazepine medication. I think the paper that we're looking at over here is interesting because they use the DORA, one of the DORAs, which is lemborexant in this case, and they argued, and we're going to jump into this in a lot more detail, they argued and demonstrated some improvements in sleep architecture, though this paper itself didn't actually look at sleep apnea severity per se. So they looked at architecture, sleep architecture, we're going to jump into, and so on. But it does open this sort of investigation, open this door potentially that if you can improve sleep architecture in these patients with sleep apnea, perhaps you could potentially improve clinical outcomes in that regard.
Oh, that makes sense. And sort of disclaimer, is this an industry-sponsored study?
Yeah, it was. This was a study that was, there was actually, this paper is based around two studies. The paper that we're looking at is based around two studies that were sponsored by Eisai, which is the manufacturer of lemborexants.
Okay, so tell me about it.
Sure. So in this paper, they took patients who it combined two different studies, and you had patients with either mild sleep apnea, defined as a traditional AHI of 5 to 15, or the second study involved people with moderate to severe sleep apnea, basically an AHI greater than 15. And the patients did not have to have a history of insomnia. Okay, so they didn't have to have a history of insomnia. And in both studies or in both cohorts, patients had a BMI of less than 40. And so for both studies, they randomized patients to either receiving 8 nights of placebo or 8 nights of the study drug. In this case, the study drug was 10 milligrams of lemborexant nightly. And so they basically did 8 nights of the study drug, either again, lemborexant or placebo, had a 2-week washout, and then repeated with what the people didn't get the first time. So if they got placebo the first 8 days, 14-day washout, they'd get lemborexant, or they'd get lemborexant for the first 8 days, and then they would get placebo after the 2-week washout period. And they did sleep studies basically in laboratory polysomnography on days 1 and 8 before either getting placebo or lemborexant. And that's the way sort of this study was designed. And then they looked specifically at outcomes such as, latency to persistent sleep, the sleep efficiency, the WASO, the total sleep time, sleep architecture, and also things like sleep efficiency and the distribution of sleep stages that patients attained. Yeah. So that was the overview of the study.
So it's interesting, though, that it was strictly, if I'm understanding you right, the idea is, can you improve sleep architecture?
That's right. They didn't look directly at sleep apnea in this paper,
Okay.
But they were looking really more at how does the sleep architecture get infected by the use of either lemborexant and comparing it, of course, to placebo.
And so the sleep apnea wasn't treated, though, right?
That's correct.
So was there a difference in AHI, or did they just not look at that?
If you look at there will be a difference between the two studies here. If you look at the AHI in the first study, the mild one, it was an AHI of 10. And in the second study, the average AHI was 44.
Wow.
Yeah, so pretty high.
Okay.
Pretty high number.
And then did that change?
They didn't report the change in the AHI in this paper.
Okay.
So I think I would just jump in real quick.
Yeah.
This was a follow-up of a previous study where they showed no change, right? So that was not the point of this study, but it's important to realize that they had done previous studies in mild, moderate, severe OSA, did not show any change in parameters of oxygen or worsening of AHI. So this was a follow-up for the sleep architecture. That had already been shown in this patient group. So this was another analysis of these same patients with sleep architecture versus, so it didn't show that lemborexant worsened anything with OSA.
Okay, but that's a really important point, right?
Yep.
Because I think that's always the hesitation that, we don't want to make sleep apnea worse. So it may not have gotten better like that CBT I had demonstrated, but it didn't get worse. It just kind of it was sort of a net neutral effect then?
Yeah, correct.
Okay.
And, I think the caveat with these studies, ethics-wise, is they didn't have very severely obese people. Everyone was a BMI of under 40. So that isn't always the patient we treat on the small sample side, but you didn't see any sort of dangerous signal. And I think the other thing that Mark had pointed out quite clearly is, benzos are always troublesome. How much is, up for debate. Z drugs findings are mixed. There's meta-analysis that says no effect. Some meta-analysis says a modest effect, right, at therapeutic doses, but we all know people do other things, take more doses, take other drugs. So I think that can aggravate the effect of a Z drug or a benzo. But Z drugs are at therapeutic doses are probably okay, right? But, I think the thing is we don't, looking for something better that doesn't have that theoretical risk as Mark had explained.
Can I tell you, I love hearing Z drugs, because I'm Canadian. So right away now I feel like I'm back in Canada. It's a Z drug. It's not a Z drug.
If the bio didn't tip me off, that tipped me off, right?
So are they all created equal? Like, let's talk about the Z drugs or the Z drugs for a minute. Because we've had conversations before about, do they preserve sleep architecture? Do they... are they all the same? Like, is ecopipam the same as zolpidem in terms of sleep architecture?
Yeah, that's a good point. I think, the data is a little more difficult to parse out, but definitely, I think there's definitely some subtle differences in mechanism, with the alpha subunits on the GABA receptor between, zalclone, zopiclone, zolpidem, and S-zopiclone, right? I think S-zopiclone and zolpidem are probably the two best studied.
Yeah.
I don't think there's any huge differences in overall architecture at therapeutic doses, but sometimes we have to go off label above it. But they definitely seem to respond, I think, clinically differently, and seem to have, at least with that zopiclone, the one probably you're most familiar with in the US, probably have a more favorable, but still somewhat troublesome profile.
But that's what I kind of thought, that one was a little bit different.
Yeah.
And I know like we probably use, so it's like Lunesta, right? We're
Yep.
apples to apples.
Yep.
So we probably use it more in the US because I think there's some sort of reason it wasn't adopted well in Canada.
Yeah, some of that was patent. Some of it is came
Okay.
quite late. Some of it was lack of coverage. But yeah, definitely, if you look at the balance of the data, acetylcholine is, as you know, Seema, is a very well-studied drug,
Mm-hmm.
and is actually appears, obviously not head-to-head, to be much less troublesome than zolpidem.
Mm. Yeah, because my mom's a family practice doc, and we will talk about, she'll say Zopiclone. And I'm always like, to this day, I'm like, okay, hang on. What is that? Is this Lunesta? Like, what drug is that? But it's different, right, in Canada?
Yeah, and to your point, it's like, yeah, S-opiclone is the sort of S isomer, right?
Okay.
And they basically purified Zopiclone, which is a very old French drug. And actually, if you look at the data with Zopiclone, it's actually pretty poor and pretty old, right? It's just, used by tradition in Canada, a number of other countries that didn't have S-opiclone, and S-opiclone has been around for 20 years in the U.S. And it's a much, I think, cleaner and more consistent, and well, at least the study shows probably safer Z drug than both zolpidem and azopiclone. So I think there are differences, and obviously zaloplan with the half-life. But as Mark said, this is a whole new class.
Yeah.
The DORA class, lemborexant, and so this is sort of testing what it's doing to airway, which it doesn't seem like much. It seems quite safe. There hasn't
Yeah.
been any case reports, an overdose or stopping breathing or anything like that that I know of. And this small study, helps sleep architecture, but in the previous studies didn't seem to make anything worse from an apnea point of view in patients with a BMI under 40.
Okay. And so that was one of my questions, that do DORAs affect the respiratory drive? So it sounds like no.
And I don't know, Mark or Mike could answer this a bit better than I. I don't even know there's any theoretical way they would,
Mm.
right? From the orexin system. There's more RAM, and we still didn't see a signal, right?
Yeah.
Just because what we know with physiology. And you also don't see a signal with sort of studies with the other, that's been tested, the other door that's commonly used, DORAs,
Mm.
right? So I think you can, and there isn't any reports of this. So again, we don't have huge giant studies, but, I think as Mark said, it's definitely something you would be seriously considering if you want to treat the insomnia with pharmacotherapy, or if with somebody who has OSA.
Yeah, it doesn't seem like, from a mechanistic point of view, I agree with the tool, that you wouldn't think that they would cause an increased collapsibility of the airway. And
Yeah.
this study is kind of cool because it shows that there could potentially be improvements in the architecture here, which is a very favorable thing. Even though the patients themselves didn't necessarily have insomnia, their sleep architecture parameters still seem to improve like in a favorable way.
So do you think it would be different for someone who had COMISA?
Well, you'd probably extrapolate this. So these are patients with untreated sleep apnea. If you took people with concomitant insomnia, like in COMISA, you'd imagine that they would also garner benefit as well from this,
Mm.
from this agent, right? From the DORA
Yeah, that's a good
lemborexant.
point. I think
Yeah.
clinically, right, this is something I'm doing much, much more often now, is, using, kind of assessing it and maybe giving a little bit of the DORA, because we know CPAP compliance is, really formed in the first number of days to weeks. That's fairly well studied, even though we don't really understand CPAP compliance that well. But to even give them something like this to facilitate compliance, if especially as Mark said, if there is an insomnia comorbidity, and I think that's a fair point. I think even though it hasn't been fully studied, not everyone does CBT I, especially if not everyone wants to do CBT I. Right now we can access CBT I, so this is a good sort of quick and reasonably safe way to kind of, to me, even though there's a lot of data, but clinically improve CPAP compliance.
So Mike, what's the right order for COMISA? Is it meds then PAP, or is it CBTI then PAP, or is it sort of PAP and hypnotics at the same time?
Yeah, I guess this is like a topic that's been studied now, I guess beginning 2017, 2018, when we saw like the advent of various controlled trials looking
Yeah.
into sequence, which is important. I think the overall message is is that concomitant CBTI plus CPAP or CBTI first, then CPAP is the preferred pathway, not the other way around, meaning not PAP first and then CBTI. But, I think, like when you look at this, it also begs the question, who are the patients that demonstrate positive response to pharmacotherapy in COMISA? Because there's obviously some people that, respond well to medications in the context of COMISA. And maybe this is just one study that allows us to think that's, we might be able to use DORA drugs safely in that comorbid context. One thing that I liked about the study is this: we're always worried about, making sleep apnea worse. And, we understand, right? REM related sleep apnea can be sensitive and might be, the time when we have the most events. And here we have a study that shows that there was an expansion of REM sleep after administration of lemborexant, but we didn't see a change in AHI. So I think that's like a safe type of signal.
Yeah, that was the one thing I thought for sure that you'd have more REM related apnea. So it was like a pleasant surprise to see that you didn't demonstrate that.
Yeah, I think it gives us more confidence in managing these types of patients.
Yeah, especially and also with the Z drugs and other agents potentially suppressing REM. It's kind of cool that lemborexant in this case increased REM. So that was a very positive thing. And I'd argue then in this group of patients of untreated sleep apnea that you'd probably want to pursue something like a DORA over a Z drug, at least for that sleep architecture nodes.
So let's take a short break, and when we come back, we'll talk more about the use of hypnotics in untreated obstructive sleep apnea. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Dr. Boulos, Dr. Khullar, and Dr. Mack about their work on using hypnotics in untreated obstructive sleep apnea. So let me ask you guys about somebody. So let's say you have somebody or somebody is in primary care and they are tired during the day and they feel that it is because they have insomnia, not sleeping at night. They get put on a DORA, but they actually have narcolepsy. What happens?
Oh, the narcolepsy is going to get way worse.
Yeah, well, that's almost a probe between type 1 and type 2, to be honest.
Ooh, tell me more.
Or IH, right? Like, because if they do better with a DORA, they don't have type 1, right? They probably have some NT2, IH, organic hypersomnolence NOS, right? So, yeah, but what Mike's right. If you're true 1, you get worse. And I have seen that. So sometimes, honestly, if they have what you just said, I'm just like, fine, take a DORA and we'll see.
Yeah, I had a patient where they unmasked their narcolepsy. They had come to me with sleepiness. We thought it was insomnia. I started them on a DORA. And sure enough, she comes back with all the, So, then she went for an MSLT. But it's a fascinating point.
Yeah, well, and especially as we're starting to recognize more the 24-hour nature of narcolepsy and that sort of, that really fragmented sleep at night.
Yeah, the DNS, and exactly.
Yeah.
And that everyone's like, there's a tetrad of narcolepsy, a pentad, but you guys are better at not, because our Xyrem Xywave is not used nearly as much in Canada as it is in the US. It's much more limited in its indication, so you kind of have to lie to get it. We don't access MSLTs outside of where Mark and Mike live are not great. And
wow.
So Xyrem Xywave is, like, I use tons of it, but, I push the envelope. And to your point right there, I think that's, that DNS is a cardinal feature of, most narcolepsy. But most sleep specialists that don't do hypersomnolence, like, you have how many people would you say actually do hypersomnolence in our country, Mark? What, 30? 35?
There's not many. Not many. So, I think less than 30.
Yeah. Just to be generous, there's about 30 of us that do hypersomnolence.
Wow. Out of how many sleep docs?
Well, probably what? 300?
Hundreds.
Yep. 400. Yep. Yeah.
Huh.
Yeah. It's so, so it's a great point. The DNS is not well known. And basically both Xyrem Xywave and pitolisant are not commercially promoted in Canada anymore. They're available, but no one talks about them.
Huh. Okay, so tell me more about what you said about REM quantity versus REM quality and fragmentation during REM?
I think it's important to realize with REM behavior towards the quality of REM, not
Yeah.
necessarily the amount.
So tell me more about that fragmentation.
Well, if you think about it, if you look up, you're on some sort of REM suppressant, like an antidepressant, like you may get this partial suppression of REM. So it's not, you're not fully reducing the amount of REM. You're just making it, more fragmented, lower quality, right? So I think that is the genesis of most REM behavior disorder. So I think this is why we see with the DORAs, they increase REM, but you don't see the increased REM behavior disorder.
Okay, that's a really important point. I hadn't considered that before. Okay.
Because we look at it, and Mike and I are psychiatrists, we see ubiquitous RBD from antidepressants in young people. Like, it's astonishing.
Really?
Right? Yeah. And some of the older ones are nasty. Effexor's terrible for it. Prozac's terrible for it, right? Like, these are, and when you look at the study, you still see REM, but it's just choppy and, you could see here's a bit here, but the paralysis is incomplete, right? Like, and I think people forget that is probably the number one cause of RBD. And I know some people say, oh, if you develop it, you're going to get Parkinson's. I would disagree with that. A 35-year-old who gets RBD on Prozac isn't, to me, at high risk. Sure, maybe. But, I think people forget that it isn't just the total amount of REM.
But Atul, is that RISWA you're talking about on the sleep study, or is it actually RBD that they start acting out their dreams?
Well, they start acting out their dreams too.
Okay, cool. Because I've seen, actually, this is jumping on to another point that I find fascinating, but I find a degree of RISWA in patients, sometimes they're on an SSRI or SNRI, and so if you look at the EMG trace during REM, you actually have a range of increased tone, and then the ASM and other criteria define that some of that's going to be clinically significant enough to call it RBD. But then in someone who has some little flickers up in their EMG channel and they're on an SSRI or other antidepressant, do you really think that's do you think that's really consistent with RBD? I don't think so. Like what you said, Atul, it's unlikely that this person in their 30s or 20s or 30s is going to develop Parkinson's several decades later. And so I think there's actually a range of I think there's probably a range of values there that might be normal and not normal. That's probably a fascinating area that needs to be sorted out still.
And that's a good point, but they act out their dreams, right? I think clinically, exactly. And then this is where the study comes in. It also depends on the study's interpreted, right? Yeah. You're a neurologist, you're doing REM a bit better than people who, kind of globally say this, to your point. And I agree. I think that it's a spectrum, right?
Yeah, and then the question is, if you stop the SSRI or it was tapered eventually, would that go away, right? If it went away, I'd be less I'd be less inclined to think this is from a future neurodegenerative issue. But on the other hand, some people are arguing that maybe later in life, the SSRI is unmasking this tendency for RISWA or for this.
And see, I disagree with that. It's just too common, right?
Yeah, that's fine. I mean, and some people will argue for, and some people argue, against, right? So,
well, and it's funny on the cohort, right? Like if you speak to a neurologist, like a ton of their patients with RBD have some sort of neurodegenerative thing. But we were speaking with some of our colleagues who work within a VA system, and they said that nearly none of them progress, because a lot of it's trauma related.
Yep.
Yeah, that's fascinating. And you wonder when you think of head injuries, right? It's about, the patients I'm seeing are probably different than those that, Atul and Mike are seeing, right, in their practices. But I've got a lot of people with stroke, dementia, and they're sort of on the fence into a Parkinsonian stage, right? Yep. Anyway, right? Just from what's coming there. But if you're getting people with trauma, psychiatric, insults and so on, then you're going to, it's a completely different.
Yeah, and I think it's almost two types, like you said. Like it's a bit different having a 65-year-old guy who has no problems. It just starts acting out. I'm like, oh, right. Versus, and doesn't respond to a lot of apnea, which unmasks it, right? People forget about that too. Versus, you stop the Prozac and it's gone. You put them on CPAP, it's gone, right? Like, versus the ones that are that are quite recalcitrant, right? That I think are far more concerning to me. But I feel like at least these days, the referrals I'm getting be like, I have RBD because I acted out my dreams. I'm like, you acted out your dreams because you were on 2 antidepressants,
Mm-hmm.
right?
Yeah.
And they're really difficult to reassure. And I think
That's just it. Yeah.
they're like, I read that I have all the symptoms of RBD, and I like your RISWA point, Mark, if it's called, right? I'm like, well, yeah, you don't quite meet, but some of them are like, they almost meet criteria
Right.
for RBD
Yeah.
because it's so suppressed and it's the MG is so low. So I think they're it's almost 2 types, right?
Yeah.
At least.
It's going to be hard, and that needs to be further studied, because there are some papers out there saying that, listen, if you act out your dreams at any point in your life,
Yeah.
you have a 90 to 100%, maybe 90 to 90 something high, percent chance of developing Parkinson's.
And I have not seen
decades,
that.
right?
Right.
So, yeah.
I have simply not seen that. Right.
Let's talk a little bit about what you said about more REM with a DORA. What does that do to RBD?
Well, it's interesting because it's informal studies, but clinically, I think you have to remember RBD. It isn't more REM; it's bad REM.
Right.
Right. And I think people sometimes forget that distinction. Right. This is why antidepressants are so notorious for causing RBD, because it isn't just REM suppression; it's also REM fragmentation. And I think we've all seen it clinically, but I don't know if it's a consistent finding that lemborexant, because lemborexant will increase REM, and datorexant seems to increase all stages about equally, so it doesn't have that sort of REM-specific increase from the limited studies anyway. That we see a lot of these, or I haven't seen a lot of these, or obviously I've seen very vivid dreams for other reasons, but I haven't seen a lot of florid worsening of RBD. I don't know. What do you guys think?
Yeah, that'll be my experience too, Atul, that I haven't seen worsening of RBD. I see a lot of patients with neurodegeneration in my practice.
You're a neurologist,
because I'm in sleep neurology. Yeah, that's right. So, so we haven't seen that I haven't seen, basically parasomnias emerge in the context of neurodegeneration, if that's sort of the question, So, and that's probably needs to be studied more, because it's just a single center, single clinician experience, at least what I'm saying. But I don't think that there's signal right now, at least, or suggestion right now that would worsen in terms of RBD.
So can we kind of compare and contrast? Because where I'm going with this is the sleep architecture. So DORA sounds like favorable effect on sleep architecture. The Z drugs or Z drugs, probably okay. What about trazodone? Is that a hot potato?
No, not really. Oh, it is. It's a good way to start fights at sleep meetings. 2 things: trazodone and melatonin are excellent ways to get people
pick a fight. Yeah,
pick a fight. Totally. And it's interesting because trazodone sleep architecture is not well studied, not unknown. It doesn't seem to really obviously affect breathing. There's a ton of great data. There's some modest stuff might increase various sort of stages of sleep, but again, that's very preliminary. It hasn't been fundamentally studied like the other drugs have, and we're talking about sort of small open samples, or these sorts of things. So that we're kind of guessing in a little bit what it does, but it doesn't seem to just from my reading, maybe increase this and this, but no huge changes that I could see. I don't know what you guys think.
I don't think it would affect apnea severity. I haven't seen that clinically.
Yeah. Yeah, definitely not the airway, but the sleep structure. There's some stuff that says more slow wave. Yeah. There's some stuff that says definitely doesn't seem to be more REM, but some stuff that says more stage 2. But again, these are open samples, and trazodone just does something to sleep in its own mechanism. And I think getting back to the mechanism of trazodone is important. It's really sort of, the 5-HT2A is a part of it, and a number of other things. There's a lot of, there's a messiness to it that may work for some people, but we don't really know a lot, but it probably doesn't worsen things for OSA.
What, but for sleep architecture, do you think it does?
I don't think it worsens sleep architecture. I don't know what it benefits, right? But clinically it's often sometimes useful.
So what about the over-the-counter meds, right? All of the Tylenol PM and all that over-the-counter stuff. What happens to sleep architecture with those medications?
Well, again, it's how well has this been studied? But the anticholinergic effect, they tend to be more sedative. I don't know if they've been formally studied right that well, right? From a
Yeah.
sleep architecture point of view, right?
Yeah, exactly. I agree with that as well. And I don't know, like we haven't seen too much literature going out, like really the antihistamines or melatonin and so on. There's not been a huge amount of literature just looking on like sleep architecture for these. I'm doing some work in my own lab looking at these sort of things, and we haven't shown, like, we did a retrospective study. This is something that is ongoing. We're looking at sleep architecture in relation to different medications. Haven't seen major changes with the antihistamines per se, and though it's not really a controlled study, like where we're following people prospectively before and after, initiation and of the drug or of the I guess of the study medication. But I suspect it probably doesn't change things too much in terms of sleep architecture. That would be my guess. Again, it would be the histamine receptors there that would be impacted.
And I think it's important to differentiate between architecture and quality, because there's
Yeah.
next day. And I think, with something like a Tylenol PM, probably if you look at it, the preliminary stuff may be a little more stage 2, but again, it's the anticholinergic effect, the next day effects. I think sometimes we get a little way too hung up on sleep architecture, not realizing it's a almost 65-year-old concept, right?
Yeah, well, and I think you're right. I think like when I was a fellow, that was kind of the teaching that, you had more N2 with sort of the over-the-counter things. But it was that antihistamine, that hangover, right? That you really, you have to factor that in, because at the end of the day, right, you're treating human beings and not, lab rats. So like at the end of the day, do you feel better? And, and is it something that'll build up a tolerance really quickly?
Yeah, you wonder if
Exactly.
there's changes in the arousals potentially, or even the EEG, you know what I mean? The
Yeah.
stuff that maybe may not be captured by sleep
Yeah.
stages or whatever. Because a lot of times people will describe waking up with, as you described already, drowsy, so
Yeah.
hungoverish kind of feeling like that, right?
Or the
But
restless
what,
legs.
yeah,
Yeah.
with the restless legs, like, I mean, for sure,
Yeah.
100%. Like in my own practice, I see a lot of people with the refractory restless legs, and we're doing some trials in that area as well. And 100%, like you start someone on a Gravol or like an antihistamine, and it worsens so much. So it may not be that there's a change in architecture, but you've elicited other things in sleep that have come out that normally wouldn't be there until that agent is introduced.
And
Yeah,
so
man.
for the non-Canadians, Gravol is a little bit like Dramamine, over the
Yeah.
counter, great for motion sickness. My mom actually brings it when she visits, because I think the little kids kind is dissolvable. Everyone loves it. Perfect dose. So that's what that is. Mike, what are your thoughts?
I think that the best point to make is that the over-the-counter sleep aids, regardless of their effects on sleep architecture, they have bad outcomes, right?
Mm,
They don't demonstrate good effects in terms of sleep outcomes, and the anticholinergic side effects overwhelmingly make it a hard choice for people to continue on. So
Yeah.
I think that's why there's very few studies looking at our sleep architecture on over-the-counter sleep aids, because overall, like the outcome to sleep is bad.
I feel like it's really hard sometimes to wean people off of them, though, unless you swap out for something prescription.
Yeah, I think so. But I think clinically, one strategy that I've used is you connect what they take to their next day, because most people will notice the anticholinergic.
Yeah.
They'll say, I slept great. It knocked me out. The Dramamine, like people take it, they give the kids on airplanes,
Yeah.
these sorts of things. But when you just like, okay, so how exactly did you feel the next day? And someone will be like, oh, I nearly crashed my car. I couldn't think at work.
Oh my gosh.
That anticholinergic is anti-cognitive. And as Mark, being a neurologist, knows, we grossly underestimate the effect of anticholinergic medication on cognition.
Mm,
Your
Yeah.
amitriptylines, your clothiapines, even trazodone to some degree, right? We forget that although they can be helpful for some people, what Mike said is very warranted. It's just they don't always connect the next day to how they slept. And I feel as a clinician, that's often what I'm doing with them, and that sometimes helps me get them off it and onto something else.
Yeah, and I also see in my practice, I mean, I see sometimes the after effects of long-term use of hypnotics. So for example, I mean, I've seen in my practice multiple times now, patients on years of benzos and now developing, they're referred by their cognitive neurologists with memory problems. It's sort of like, can you get them off the benzo? We think it's causing their dementia or causing their mild cognitive impairment. So it is quite striking, that long-term use of these. And it's borne out in the data as well. It's borne out in the data as well that these long-term use of benzos, and probably I would extrapolate even to some OTCs as well. Because I think there is some literature out there now that I recall. I think the antihistamines might actually suppress deeper stages of sleep.
I thought so, yeah.
Yeah. And so I'm just going to backtrack a little bit on what I might have said a few minutes ago. And that the antihistamines can do that. And we know that stage, for example, N3 sleep, is a really important stage of sleep for clearance of neurotoxins in the brain. So if you're getting less, or if someone's getting less N3 sleep over a long term, over many years, over decades, that's probably bad for you. That's probably inducing or contributing towards a buildup of neurotoxins in the brain that can lead to dementia, stroke, and other bad things, particularly over long periods of time. So I just can't, just like what Mike and Atul already said, I just like long-term use of probably any of these agents is probably not a good thing for your brain.
So what about DORAs and long-term use?
Well, I think, looking at, again, they've been out for a few years, definitely any signals. I would just like to also backtrack on what Mark said. I think definitely there's a linkage, but especially if you look with Z drugs and some of the newer case control studies, the dementia risk is maybe, but they're definitely affecting your memory while you're on them, right? And that's quite clear, right? But the flip side is if you don't sleep, that's a dementia risk too. So you're playing a little bit of teeter-totter. But to your point, Seema, I think the DORAs, it's less of a teeter-totter, right? You don't seem to have the long-term issues. There are some animal data showing that DORAs can, reduce tau, right? Again, that's animal stuff. That's pretty early, but, and I don't know if that's actually the DORA or just, as Mark was saying, better N3 sleep, but you're not sort of doing the teeter-totter. And one thing we haven't mentioned in this whole discussion is the fall risk. Right.
Yeah.
That's, that's one thing that Z drugs and benzos are definitely have a fall risk. Trazodone has a fall risk. Mirtazapine has a fall risk. All these things have fall risk. Now, it may not be the reason. It's usually the antihypertensive and people pick on the sleeping pill, but, there's still a clear fall risk, and DORAs don't seem to have that signal. Right.
Interesting.
And that makes it another sort of, probably better thing for long-term use. And we're not seeing any signals, and they're fairly heavily monitored in many countries in the world. Like there's about 5 million prescriptions of DORAs in Japan. And
wow.
We that's where they were invented, and, they have good public coverage there, and they know how to use them, and we're not seeing those signals.
Oh, I didn't realize that. I thought there was a study on zolpidem because it was a big thing about falls. And then there's one study somewhere that said that the falls risk decreased because people stayed in bed.
Yeah, and there's that balance. But if you look at the larger studies, Z drugs definitely have a link.
Yeah.
Is it the same link as an antihypertensive? No. And I think any psychotropic can have a fall risk. But you're, like you said, you got it. If you don't sleep as well, you're also at a fall risk. So
and so there was a study that was published in Nature, I think Cell, and it was about mice. And the scientists had given them whatever mouse dose of Ambien or zolpidem was, and found that the glymphatic clearance had decreased by, I think, about 30%. And the argument was, well, okay, are we going to accept 30% decreased glymphatic clearance over not sleeping at all?
Yeah.
You had kind of talked about, it's like a risk mitigation.
Yeah, exactly.
Yeah, that's the tough part with it, right? But I guess, if you have the choice with the patient in front of you, can you mitigate that risk, right? And that's always the choice you have when you're a clinician. I just want to add to one of Atul's points as well, because there's actually a human study in suvorexant that showed a decrease on tau phosphorylation and beta, and also amyloid beta as well in patients with in cognitively unimpaired patients.
Oh, okay.
Who got randomized to suvorexant, different doses of it. And the bottom line is they were able to demonstrate that suvorexant actually decreased the tau phosphorylation of amyloid beta in the central nervous system. So that was, I think they did lumbar punctures. I'd have to look it up. But the point though is that there is some human evidence as well, aside from the mice, that, that the DORAs potentially can, they have this potential mechanism for I wouldn't say improving cognition, but at least preserving cognition. Obviously, this would be a great spot for a clinical trial to test. In the long run, can you start cognitively impaired individuals who are having difficulties with sleep and improve outcomes in that regard? That would be a pretty cool study.
So, Mike, let me ask you this. We've kind of talked about the different mechanisms, right? So sort of GABA is sleep promoting versus like the DORAs are, turning off wakefulness. So are we going to start phenotyping insomnia? Like who needs the GABA versus who needs impairment of wakefulness?
Yeah, that would be like the greatest, achievement, at least for pharmacotherapy for insomnia, right? That's the holy grail. Because some proportion of our patients that meet criteria for insomnia disorder are going to be folks that maybe have like impaired GABA activity when it's time to sleep.
Okay.
And there might be a second phenotype where they have inappropriate activity, like higher activity that's inappropriate at nighttime of the orexin pathway, which is wakefulness promoting, right? So, the group B would probably demonstrate better outcomes taking DORA medications where we block orexin. And then for the people with impaired GABA activation at night, maybe they need GABAergic medications like Z drugs. So, the question is, how do we identify that?
I was going to say, how do you figure that out?
Yeah, or in a way that's accessible to the average clinician, and
Right.
not just like in a laboratory. So,
Because I know anytime I've thought about writing for a DORA, obviously we have to trial and fail, 3 medications. There's one insurance company that wants you to document that you've tried and failed 5 alternatives before they will approve one. So we have a lot of barriers in the US to even having our patients, try these medications. Is it the same in Canada?
Not really. It's interesting that you say that. Like, obviously, they're, private coverage will cover them without usually too much trouble. They're on the public formularies, and they cost about a lot less. So a lot of people buy them out of pocket. I don't know, everyone's going to start racing to Canada now to get them. They're about $2-3 a day. But if you kind of look at other countries where they are on public formulary, Canada and the United States are the only 2 G7 countries, that don't have a form of a DORA on a public formulary. Like the evidence is that strong.
Wow.
You see them used very quickly first line. Like, they've just kind of been approved in Europe and in Asia. They're both approved in China, and they're kind of flying off the shelves there. Like these are, to me, first line pharmacotherapy for insomnia. Like, I think it's fairly clear by any basis of evidence-based medicine, right? The safest, they're the best long-term data, and they normalize sleep structure and have some next day outcomes. I think the other point that Mike got to was all insomnia is not the same.
Yeah.
And the field has been notoriously poor at phenotyping insomnia. Who's going to respond to CBT I and who's going to respond to this or that. And I think that limits us too. We phenotype sleep apnea reasonably well, even though it isn't quite entrenched yet.
Yeah.
But that I think is going to be sort of the next going forward, and we can maybe pair drugs to this. But, DORAs to me, they're first line drugs. It's simple as that. Including an OSA.
Do you see a lot of tolerance building out?
Tolerance, no. I think anything that works in the brain, being a psychiatrist, can have something called tachyphylaxis.
Sure.
And I think it's important to understand the difference. Tolerance is you need more and more to get the same effect. That doesn't happen in DORAs.
Okay.
They usually just plateau at some point. But what you do see, and you see with any drug, at least in the brain, is sometimes it just stops working. We see this with antidepressants. We see this with stimulants. We see this with, bipolar medications. And I would say I've seen that with DORAs. This tachyphylaxis, it's sometimes it just stopped working. But there's no sort of evidence of tolerance or dependence from the studies, and nor anything that I've seen clinically. But I'll also ask my colleagues who see different people than I do. So,
yeah, I think the DORAs are special because they're really working on the orexin brain network, right? So it's not going to be something um, like, for example, a benzo is going to hit your chloride channels, right, and lets out, and that's how it sedates, and then it has long term effects on the brain just because of the continuous release of through the benzodiazepine systems of the brain. But the DORA here is working on a brain network, and so that's why, even though there may be an effect short term, there's often an effect after several weeks and months that's a little bit more pronounced and a little bit more robust in that way.
Hmm.
So I think that's kind of cool, at least from a brain network point of view, with how these medications are contributing to the brain health and improving sleep.
So if you get tachyphylaxis with one DORA, can you swap it out for another?
I was going to say I was going to talk from clinical experience that if someone can't tolerate one DORA, then I've been comfortable switching to another DORA, and often I've had success with that, either in terms of efficacy or just tolerability. So we'd like to know what everybody else thinks as well.
Yeah, I think they're different enough to be worth trying. Like they both, they hit OX1 or OX2 slightly differently. So I wouldn't say if you fail one, you're going to fail the other. I'm not sure about the tachyphylaxis concept, but I think just overall, if one doesn't work or one loses effect, that I think it would be worth trying another. And, as Mark said, it's a pretty easy switch. Just stop one and start the other. And that's the other advantage of this. There isn't, this sort of cross tapering, or, people can kind of stop and start them as they see fit, right? You don't see any sort of withdrawal with them. Like, again, that not everyone has an orexigenic type of insomnia. It would be great to know, right? But that's a little difficult.
That'd be great.
But that's kind of where the field needs to go. But the point is just for ease of use, functionality, safety, I tend to use them first. Obviously you have access issues if possible.
Yeah.
And then we worry about all the other dirtier stuff.
So Mike, you don't think you need to swap from like a DORA to like a zolpidem, like a Z drug, and then back?
No, like this is just like our clinical expertise and consensus, right? But in the same sense, like let's think about the time before the DORA drugs made their way to the market, right? We would treat patients with one Z drug and then switch them to another should the first one fail, and vice versa. So I think it's a similar situation here. If you fail one DORA medication, you can try the other one, and if failing that, maybe trying a Z drug.
That's fair. That's fair. So bring it home for me. What is the take home of this message? And I'd love to hear final thoughts from each of you. Mike, you want to start?
I think what the study shows us is that we have like a medication that we can administer in people with untreated sleep apnea. It didn't show any signal of worsening sleep apnea in terms of AHI or oxygen saturation, and that bodes well for us because, when we think about patients, that we test in labs, and many of them are anxious and they say that they can't sleep. They have concerns about wearing CPAP and how that's going to affect their sleep continuity and sleep initiation. Studies like this give us some confidence to be able to prescribe them, and to do so, and it means that we feel safe.
Mark, what about you?
Yeah, I agree with Mike. It's a great study that shows you can preserve in patients with untreated sleep apnea. You can preserve and you potentially even improve sleep architecture, and you potentially increase REM as well. So that's very, 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 very good. I also just want to comment on the study being sponsored by an industry partner. I mean, as a scientist running a lot of trials, it's very, very difficult to get funding for grants these days, and I think everyone listening to this may agree with that.
Yeah.
And so I'm not really sure how a company would otherwise, move ahead a product that they have. You know what I mean? So,
yeah.
And again, there has to be, of course, care in how we interact with industry and so on and so forth. But, at the end of the day, to develop the research program that they've developed here around lemborexant would have been probably impossible with public funded dollars. I can't imagine going to NIH or CHR in Canada and asking for funding to do something like this. So I don't think there's any other way to have generated this knowledge, and so I just want to throw that in there because sometimes people look at this and say, well, industry sponsored. It was blah, 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 blah. But in all fairness, how do you move ahead a product and how do you generate this knowledge? I'm not sure there's much, no other way to do it right now in today's society.
Yeah, I mean, it's expensive. And I mean, like, look at tirzepatide and look at, how do we understand about the rest of these medications? So your point's well taken.
Thank you.
Atul, what about you?
Yeah, no, I think I agree with Mark 100% on that. So yeah, that's just kind of the way it is, right? Like, and there's a lot of fence posts with industry now, right? With these sort of studies and the research, someone who's done a lot of trials over the years, it's much harder than it used to be. So you could probably put a lot more faith in it. But I think in summary, again, it's a small pilot proof of concept study, it just adds to the sort of, that's the safety data of DORAs in a special population. It's a small study and it, just says that, okay, yeah, the sleep's improving and even in these patients. And, individually, it's like one sort of data point, a small one, but it really kind of, as Mike said, really kind of emboldens us to kind of, these are pretty safe drugs in most populations. And they're helping this in untreated sleep apnea, and it's something to really consider, right? And clinically, I think, extrapolating we have, I'm just like, okay, well, maybe you want to treat the insomnia first with a DORA before you get up on CPAP, while you're doing CPAP, these sorts of things to just improve compliance. So I think that would be the direct takeaway.
Well, thank you all for joining us today and helping us to better understand how hypnotics can be used in our patients with untreated obstructive sleep apnea.
And thank you, Seema, for hosting.
Yeah, thank you.
Thank you, Seema. It's been a pleasure.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.